Well, thank you, everybody, for coming to the Sydney Marie Snyder Endowed Lectureship. If you recall, we were going to have this in February when we had the fake snow. And so, Jack Stevens, thank you for rescheduling at that time. And I apologize for canceling that day when we had a 1/4 of an inch. but I, okay, fine. Half an inch. But I do apologize. I'm going to do this a little bit backwards because I do want to respect Sydney and her family, and Dr. Greenberg is going to say a few words. I'm going to introduce Jack first, and then I want to tell everybody about Sydney Snyder and the family that's really generously endowed this lectureship and helped us think about safety a little bit differently. Jack Stevens is a psychologist at Nationwide Children's Hospital. He's a sleep psychologist. He did his PhD training at Indiana. He works primarily in sleep medicine. He spends 20% of his time, his academic interest in behavioral economics. And you probably all don't recognize that word too much. I've seen him speak a couple of times, and just every time I hear him speak, I get really excited. I think the best way to describe Jack is what his boss said. He's an N of 1. Okay, so he's an N of 1, a very unique individual. But just in speaking to some of our groups today, I think when we look about safety, how are we going to go to the next level? We've got to do things differently. We have to approach problems differently. And I hope we're going to look back a little bit and say, you know, Jack asked us, Dr. Stevens asked us to think about things differently, and that's what we're going to do. So I look forward to hearing the lecture for about 45 minutes and some questions. I do want to pause for a moment and reflect back on Sydney Marie Snyder. I did not have the pleasure of knowing her or her family, but many of you in this room, Dave Stockwell, Jay Greenberg, Dr. Wessel, knew this family well. And let me read a little bit about the endowed lectureship, and then Jay's going to say a few words about her family. So we're here to honor Sydney, who is obviously a very special little girl. She was 7 years old when she had a diagnosis of acute lymphoblastic leukemia. In September of 2007, she came here, and Jay will tell us that, from Virginia to Children's National to be treated on an experimental protocol. Her treatment was really one of the last options for her. Before coming to us, she'd sustained multiple relapses, and all of the treatments, including the BMT, the bone marrow transplant, had failed. While she was here at Children's, there was a medication dose error during her protocol on the study drug. As a result of this error, if you're familiar with study protocols, she had to end the experimental treatment. She subsequently died of her illness, leaving a grieving family and a distraught children's team, all from that dosing error when she was on the experimental protocol. We acknowledge the fact that we failed Sydney, her family, her friends, and of course, when the family comes here, they expect that we keep their children safe and do no harm. From hearing from David Stockwell, who's interacted with the family, they're a very humble family, a firefighter and a teacher, and they gave their settlement back to Children's, right? We admitted we made a mistake and we settled with the family. They gave it back to Children's and said, we want you to work on your processes, do things differently, and we don't want this to happen to another child. So hopefully, Jack, Dr. Stevens will encapsulate that philosophy and how we think differently and we approach our families. Jay, thank you for being here. Jay Greenberg took care of this family in Virginia and when they came here. And Jay, I'd love for you just to say some of the positive things about Sydney to remember her.
So I took care of this young lady from, I think I told the family she had leukemia, and her initial treatment before she relapsed. And as you heard, she had a difficult time after relapsing. When Rahul caught me outside and we were discussing her, I said, I don't want to think about the negatives, because those who are in our field know that we remember the positives. She was a wonderful little girl. I can picture her playing in our play area. And they were a wonderful family, fully participant in all the wonderful things that go on in the hematology-oncology sector. So I choose to remember the good, and that's how I'll think of Sydney.
Thanks, Jay. We appreciate you, and thanks for putting you on the spot there. So let's make the difficult transition to Dr. Stevens, and I'm sorry to set you up like that, but I do want to remember Sydney and why we're here, and we look forward to your talk and some questions afterwards. Thank you.
All right. Thank you very much for the invitation. Today I'm going to talk to you about a field called behavioral economics. So when I talk about behavioral economics, I'm talking about a framework of strategies that can be used to change both patient as well as clinician behavior. So on the patient side, what can be done to encourage patients and their families to follow through with recommendations made by their healthcare providers? And on the clinician side, what can be done to encourage clinicians to follow evidence-based practice guidelines? To emphasize the importance of adherence in healthcare, let me offer this following opening quote. Increasing the effectiveness of adherence interventions may have a far greater impact on the health of the population than any improvement in specific medical treatments. So what I'm going to do this afternoon is I'm going to talk about behavioral economics, and the bulk of the time will be spent talking about two categories of strategies, those having to do with framing and social influences. And part of the talk is going to be devoted to changing clinician behavior. The other part is going to be devoted to changing patient behavior. And then I'll offer some of my thoughts at the end as to what I see are some of the challenges and opportunities for BE moving forward. So I do have this opening request. If you hear about a reference or an idea that you think is relevant for your purposes, please be an active learner. Jot yourself down a note, take out your mobile device and set yourself a reminder. I think when you learn a little bit more about behavioral economics, you're going to see why I've made this opening suggestion. So behavioral economics is an interdisciplinary field that features insights from psychology, economics, and marketing. Its goal is to improve individual decision-making. Historically, a lot of that focus has been on trying to improve consumer or financial decisions. So what can be done to encourage people, employees, to set aside more of their salaries for voluntary retirement savings programs? Or what can be done to encourage people to cut back on their home energy usage so they'll save on their utility bills? But more and more behavioral economics is being applied for healthcare purposes. A lot of that focus has been on trying to improve adult health. Relatively little focus has been on trying to change pediatric health. So let me briefly talk about my work in this area. So for this first article, I teamed up with a health services researcher at Nationwide Children's by the name of Kelly Kelleher. And he and I considered how you might use BE strategies to encourage parents to follow safe infant sleep practices. We know in the United States there are hundreds of thousands of parents who don't follow the ABCs of safe sleep when it comes to infants under the age of 1. Secondly, for the second article, I teamed up with an epidemiologist whose expertise is breastfeeding, and she and I considered how you might use BE strategies to encourage women who have an excess supply of their own breast milk to donate that excess supply to a human milk bank. The third and fourth article had to do with BE strategies for sleep interventions, as well as chronic physical illness regimens for childhood and adolescents, so conditions like diabetes, asthma, cystic fibrosis. And for the fifth and final article, I really thought about how we might use BE strategies to change clinician behavior within quality improvement. So to give you a little sense how BE is gaining more and more traction within healthcare, I recently did a PubMed search using some key BE terms, and I really restricted it to the most prestigious healthcare journals out there. I could only find one article from the 80s, 0 from the 90s, just one published in the 2000s, and I was already able to find 12 articles in the yet-to-be-completed 2010s. So let's talk about what behavioral economics is not. BE is not the same as economic behavior. That being said, I'm going to give lots of examples from the business world, but when I talk about these examples from the business world, I'll quickly give examples from healthcare to hopefully make it relevant for your purposes. BE is not the same as mental health economics. Mental health economics pertains to the financial ramifications of psychiatric illness and psychiatric treatment. So mental health economics would address questions like, what is the cost-benefit ratio for different psychotropic medications for schizophrenia? I think you'll see the topics I talk about this afternoon are very different from that. And BE, because it has economics in the phrase, some people will think that this is solely about money or solely about financial incentives. In fact, that's going to be a very small part of what I'm going to be discussing this afternoon. So here's an image from behavioral economics. It's actually from the popular press book Nudge by Thaler and Sunstein. I think this image really summarizes what BE is all about. There's no doubt that that adult elephant is having great influence where that baby elephant's going to move, but if that baby elephant wants to veer off course, he or she can certainly do so. This is the essence behind behavioral economics. You're trying to influence people in a particular direction, but at the end of the day, they walk away with a certain degree of freedom and choice. The other thing I want you to notice about this image, both of the elephants are faced towards the east, and east is a key acronym we're going to talk about when it comes to BE. So in contrast, this is not behavioral economics. The baby kangaroos have no freedom whatsoever. They have to go wherever the mama kangaroo takes them. Scenario 1. Despite continuing education presentations, practice parameters, and high-quality empirical studies, some clinicians are not following certain best practices. How would behavioral economics address this situation? So we're going to talk about something called an accountable justification. So this was an article that was published in JAMA last year. And what the authors were trying to do is they were trying to reduce inappropriate antibiotic prescribing through actually changing messages through an electronic health record system. So what would happen is if a clinician put in a diagnostic code that was not consistent with an antibiotic they just prescribed, so for example, prescribed penicillin for influenza, the clinician would be asked to write something called an antibiotic justification note, to take a sentence or two and actually write out why they're deciding to do this clinically. What also happened was this: if the clinician didn't write anything out, they would get this message. If you don't enter anything in this box, no justification for prescribing antibiotics will be added to this patient's medical record. And the red letters and the capital letters, I did not add that. That was actually part of the actual intervention. Now, I think this is a controversial example behind behavioral economics. Some people find this a bit strong and off-putting. Other people really like this example. But let me tell you about the results. This actually reduced inappropriate antibiotic prescribing, and it did so without diagnostic code shifting. So let's step back and think a little bit about why this intervention might work. And this goes back to the EAST framework: easy, attract attention, social, and timely. And it really gives us an opportunity to understand the difference between traditional economics and behavioral economics. Easy. Traditional economics says we're very sophisticated decision makers. We usually decide things that are best for ourselves and others. Behavioral economics views us with more skepticism and says, you know what, sometimes we don't always do the right thing. And if you want somebody to do the right thing, you need to make it as easy as possible to do the right thing and as difficult as possible to do the wrong thing. So in the antibiotic example I gave before, it's going to take a little extra work to actually prescribe that antibiotic in the situation in which it may not actually be warranted. Attract attention. Traditional economics says we have a ton of attention capacity, a ton of ability to remember things and utilize them effectively. Behavioral economics, again, views us with more skepticism and says that if you really want people to act upon information, you've got to make that information memorable and salient. And certainly that type of message on the EHR is something that you don't see all the time. Social. Traditional economics says, provide me with good scientific objective information, I'm going to make the right decision. Well, this intervention didn't have anything to do with that. It didn't remind clinicians that antibiotics can have side effects or that they're not appropriate for certain conditions. What this intervention did instead is really rely upon social influences, the idea that somebody else would actually see this justification and people want to keep their reputations and make sure that they're perceived as competent clinicians. Timely. Traditional economics says, guess what? If you attend a forum like this, like Grand Rounds, when it comes to actually applying this information 6 weeks down the road when you're in the middle of a clinic with the fourth patient, you're going to be able to take that kernel of information and be able to do the right thing. Behavioral economics says, you know what, try to give us timely reminders. If you give us timely reminders as we're making this decision, we may actually reach better decisions. Let's move on to strategy number 2. Peer comparisons. This is where a clinician gets feedback not only about their performance, but how they compare relative to their peers. And again, this is the idea that social influences can encourage people to behave more optimally. So before we talk about healthcare, let's talk about a hotel towel study. So several years ago, they were trying to find out a way to encourage hotel guests who are staying more than one night in a hotel room to reuse their towels, to actually hang up those towels over the shower rod, indicating to housekeeping that they didn't want fresh towels each and every day. And if you stayed in a hotel, you may have actually seen those placards before, reminding people that if they reuse their towels, it's good for the environment. Saves on hot water, saves on detergent. As it turns out, that's not the most effective way to get people to reuse their towels. What works better is to tell people simply that most hotel guests who stay more than one night reuse their towels. And what works even better than that is to tell people most hotel guests who stayed in your exact same room before have decided to reuse their towels. I stayed in a hotel room last night. The last thing I want to think about is what somebody in my hotel room did previously. But nevertheless, social influences can actually sometimes nudge us in ways that objective information can't. So why do clinicians respond to getting information about what their peers are doing? Some may respond because basically if they find that other clinicians are doing this, they view it as generally acceptable. They may say, you know what, if other clinicians can do this, it enhances their own self-efficacy. If provider A can pull this off, then I can do this just as well. I can pull this off as well. Some clinicians may respond because of relative performance. You've probably heard the statistic before. 85% of people think they're above average drivers. We as humans like to think about ourselves as above average. When we get feedback that we're average or even below average, we don't like that. That motivates us to change. Now, of course, sometimes these social comparisons can backfire. You have somebody who's really rebellious. They may learn what their peers are doing, and that may actually move them in the opposite direction because they want to do something different. Now, these peer comparisons actually worked as well to reduce inappropriate antibiotic prescribing in that JAMA study I mentioned just a minute ago. And we can talk about different parameters for these types of interventions. But I want to focus on one particular parameter, and that's the idea of giving different feedback for low versus high performers. So when I talk about this example, I want to talk about one of my favorite TV shows, Seinfeld. So this is going to be a hypothetical example, but this is actually based upon real energy users in the United States. It was down in the southwest part of the U.S. So how might behavioral economics reduce the energy bill for 129 West 81st Street? So let's think about two neighbors, Kramer and Jerry. So they get feedback about their energy usage, how they compare to the overall neighborhood average. So somebody like Kramer, month one, gets feedback that he's a high initial energy user. By getting this type of peer comparison feedback, we'd expect his energy usage to go down in month two. Here's the problem, Jerry. He's a low initial energy user. When he learns that he's a low initial energy user, his behavior goes the opposite way. Basically, he says, why am I cutting back on the AC and the hot showers when other people aren't doing the same thing? And what you'll see is that the total energy usage for the neighborhood hasn't changed. Everybody's gravitating towards the middle. And that's not what we want in healthcare. We want those people who are performing well to continue to perform well, but we want those people performing poorly to do better. So what actually worked in this study is to actually give somebody like Jerry smiley face icons on their energy bill in order to encourage them to be low initial energy users over time. Now, I don't want to sound naive and just to suggest all we need to do with healthcare is give people smiley faces. But I do want to suggest that we need to think about ways of recognizing top performers. So what they actually did in this Meeker study, for those people who rarely wrote an inappropriate antibiotic prescription, they would actually get subject headings in emails that actually would tell them, quote, you are a top performer, because they didn't want those individuals to gravitate towards the middle. Strategy number three, public commitments. Different study by Meeker and colleagues a couple years earlier. So what they did in this situation is they actually did a randomized trial of what are known as poster commitments, again, trying to reduce inappropriate antibiotic prescribing. So what happened in this situation is half the clinicians would make posters of themselves. They'd have a picture taken, they would actually sign the poster, and there'd be text at the bottom of the poster publicly committing to prescribing an antibiotic only when absolutely necessary. And these posters would actually be put in public areas, examination rooms as well as more private areas, like both waiting rooms and examination rooms, I should say. The other half of the clinicians did not actually make this poster commitment. And what was found is those patients who saw a clinician who made a poster commitment, less likely to get an inappropriate antibiotic prescription relative to the control clinicians. So this may work because basically you're making the behavior really salient. It really stands out to the clinician that an antibiotic should only be prescribed when necessary, and it also stands out to patients as well. The other reason why this might work is because you're trying to motivate clinicians to avoid loss of reputation. If you publicly committed to doing something, you don't want to feel like you're going to go back on that word and have that embarrassment. Strategy number four, visual images. So this also, I think, is a little bit of a controversial example I'm going to give. It actually comes from the book Switch from a few years ago. So what they were trying to do is they were trying to actually reduce errors in dispensing medication in inpatient units. So what they decided to do in this particular QI initiative is they compared nurses wearing regular scrubs to nurses who would actually wear orange medication vests. Nurses hated this. They thought it was tacky. They didn't think it was attractive or the right thing to do at all. Clinicians hated this as well because the deal was if nurses were wearing an orange medication vest, they could not be bothered. Basically, clinicians needed to wait to interact with the nurses because the nurses needed to focus on this very vital task. So everybody hated the intervention. But then they looked at the results, and the results worked. It actually reduced medication errors, and it actually was rolled out across a large hospital system. Here's also one of my favorites when it comes to visual images, and this is a little bit different from healthcare. Maybe you'll think if it has any relevance for your purposes. They were trying to decrease littering in a university cafeteria. So when they gave some of these messages on a poster, the control message was something like an environmental image, something like flowers. What worked better was to use something called an eye image. So not an entire face, just the image of the eyes. The eyes are kind of a sim image to us that we need to do the right thing, it appeals to our conscience. And this actually reduced littering in a university cafeteria. It makes me kind of think, are there certain things within healthcare, if we actually use visual images, we can kind of nudge clinicians in a particular direction. It also goes along with the idea that sometimes a picture is worth 1,000 words. Fifth and final strategy for changing clinician behavior, something called framing. So I want to imagine that half the people in this room saw picture 1, the other half of you saw picture 2. Let's look at those two pictures again. Picture 1, picture 2, side by side. My guess would be the half of you who saw picture 2 would have a more favorable view of the rose than those of you who saw picture 1, even though those roses are absolutely identical in terms of size, shape, and color. This is the idea of framing, that basically if you present an idea one way, you may get a different response than if you present it in a slightly different way. So one of my favorite examples when it comes to patient safety is, how do we encourage clinicians to wash their hands? So Grant and Hoffman did a study a few years back, and they compared different messages. So one of the messages that they actually tested was the following. Hand hygiene prevents you, meaning the healthcare provider, from catching disease. That's not the most effective way to get clinicians to wash their hands, at least according to this one study. What worked better was to write out in a poster form, hand hygiene prevents patients from catching disease. And the idea behind this is that healthcare providers may say, you know what, I'm immune to a lot of this infectious disease. I've been exposed to so much over the years, I'm not going to catch anything. But when looking at it from the patient perspective and realizing they may not have the same degree of immunity, that actually seemed to motivate them to do the right thing. Another one of my favorite examples of when it comes to framing, now we're going to move into changing youth and parent behavior, encouraging youth to purchase fewer sugar-sweetened beverages. This was actually a study that was done in Baltimore. So they actually compared different messages that would actually be posted at convenience stores. So sometimes the messages, in essence, just posted caloric information. The message would just remind people how much, in terms of calories, were in particular sodas, say 250 calories, or saying that's 10% of your daily calories. There's a better way to frame this. What worked better was to actually frame it in terms of saying, it will take you 40 minutes of jogging to burn off this one soda. That actually seemed to reduce the purchase of those sugar-sweetened beverages relative to giving them this more objective scientific information, at least when it comes to the caloric count. So let's go on to scenario 2. So despite using motivational interviewing and communication training to resolve family ambivalence and conflict, some parents and or youths are not adhering to their treatment recommendations. What would behavioral economics suggest under this scenario? So again, I'm a psychologist by training. I very much like motivational interviewing. I very much like trying to engage and build rapport with families, but sometimes I recognize that that doesn't actually produce the change that I want. So the first strategy we're going to talk about is something called changing the default. So this is changing the default from opt-in to opt-out. Classic example, retirement savings programs. So for many years, what employers would do is they would say to an employee on the first day, if you want to set aside a portion of your salary for the voluntary retirement savings program, you can do that. All you need to do is to turn in some paperwork, turn that into human resources. A lot of employees never got around to doing this, and when it came to their retirement time, they wish they actually had more money in their retirement accounts. Then tax laws changed, and all of a sudden a lot of employers switched to an opt-out approach. So under the opt-out approach, what would happen is an employee was told on the first day, we have already decided that we are going to set aside a portion of your salary, say 3 or 5 or 7%, for this voluntary retirement savings program. But if you don't like that arrangement, you want to get as much money as you want right away, you can opt out of that agreement. All you need to do is complete some paperwork, turn that into human resources. And what they found is people are much more likely to save under the opt-out approach than under the opt-in approach. So why is this default powerful? First probably has to do with status quo bias. We're all really busy. We often like to follow the path of least resistance. The other reason why this default may be powerful is it may actually signify a preferred option under confusing conditions. So maybe the person, in this case the employee, doesn't know what they should be doing in terms of retirement, looking to the employer for some guidance. What are some of the ramifications for health care? We're going to talk about vaccinations first of all. So there's an observational study published in Pediatrics a few years back. So Douglas Opel and his colleagues at Seattle Children's did a study in which they observed primary care providers introducing the topic of vaccines to parents. Some primary care providers used a natural opt-in style. They would say something along the lines of, what do you want to do about shots today? Other primary care providers used a more natural opt-out style. They would say something along the lines of, we have some shots we need to do today. Now, under either of these situations, what do you want to do about shots today? And we have some shots, what do you want to do about shots today? And we have some shots we need to do today. A parent can agree or disagree to get their kids vaccinated. But what was found is parents were much less likely to express resistance under the opt-out approach than under the opt-in approach. Brewer and colleagues took it a step further. They did an intervention study that was published in Pediatrics earlier this year. And what they did is they actually trained half the providers in an opt-in style and the other in an opt-out style when it came to introducing vaccines. And what they found is that those providers who were trained in the opt-out style had higher rates of HPV vaccines for the younger adolescents. I think this type of change in the default can also have ramifications for medication adherence. So when we think about medication reminders, for example, it's probably not particularly novel to suggest to a family, hey, set yourself a reminder that your child needs to take medication at those times. But what BE would say is take it a step further. BE would say is when you're there in the clinical situation, let's get out your mobile device right now and let's actually set the reminder with the family on their mobile device. The family can disagree to have that happen. They can turn off the reminder as soon as they leave the clinical setting, or they can disregard it entirely once they get home. But they'd be more likely to actually get a medication reminder under opt-out versus opt-in. You can think about some of the same things happening when it comes to medication refills. There's some literature from the adult world to suggest that those patients who actually get prescriptions through mail order pharmacies where they're set refills every 30 or 90 days have higher adherence rates than those who operate under the opt-in system, where they actually have to pick up the prescriptions every 30 or 90 days at a brick-and-mortar pharmacy. Final example, changing the default, something called refill synchronization. So this is the idea that basically if you can make it easier for people to get multiple medications so you can actually sync it so refills are due at the same time, you can actually increase adherence versus people have to picking it up at all these different time points if there are multiple meds. Strategy number 2, something called the compromise effect. So many years ago, there was a manufacturer of a bread-making machine. This machine cost a few $100s. People wouldn't buy this model. So what the manufacturer decided to do was to establish a second higher-end model that cost a few $100s more, had fancier features. People wouldn't buy the original, people wouldn't buy this expensive model, pardon me, but the original model looked like a great deal by comparison. Sales for that went through the roof. This is the idea behind the compromise effect. We often like to select something in the middle because it looks like a better deal by comparison. It doesn't look like we're selecting something at the extreme. What might be a clinical application of this? So I am the psychologist for my hospital's sleep disorder center. And one of the things I have to do periodically is work with adolescents who have insomnia. You can imagine that I'm not a very popular person when it comes to the possibility of reducing caffeine intake. So my natural inclination as a clinician is to try to make it as easy as possible to suggest, hey, why don't we talk about cutting back on your caffeine or restricting it to the first part of the day. Hopefully it'll be out of your system come bedtime. Compromise effect would suggest I'm making a mistake. The compromise effect would suggest not only should I be talking about a restriction option, I should also be talking about a complete elimination option. When I talk about both of those options simultaneously, all of a sudden that restriction option looks more reasonable by comparison. And there is some evidence from the sleep world to suggest that either of those options can actually reduce insomnia. So I'm going to talk out of both sides of my mouth, and I'm going to talk about now restricting the number of options as opposed to increasing the number of options. So this goes along with the expression less is more, as well as when you emphasize everything, you emphasize nothing. So let's talk about choice overload. First of all, a couple examples outside of healthcare. So years ago, they were doing a study in which they were trying to get people to buy jams. And what they did in one condition is people could sample one of 6 different jams for free. And then they tracked whether or not somebody actually purchased a jam. What they did in another condition is they allowed people to sample one of 24 different jams for free. And then they tracked to see whether or not somebody would actually purchase a jam afterwards. And what they found is people were more likely to purchase a jam under the 6 jam condition than under the 24 jam condition. It may have been a bit overwhelming to try to make those small distinctions between all those different options, and people said, you know what, I'm just not going to purchase anything at all. Retirement plans. What's been shown is that if an employer offers more retirement plan options, the more options they offer, the less likely it is that an employee will select any plan whatsoever for their voluntary retirement savings. In essence, what will happen is employees are trying to struggle, okay, how do I choose between plan number 38 and plan number 42? This is really overwhelming, and they may actually put off that decision when it would have been better for them to actually have fewer plans to select. So about 20 years ago, they did a study in JAMA, and what they did is they gave family physicians, half of them, this scenario. Imagine you're seeing a 67-year-old patient with severe hip pain. You're likely to refer this patient on to an orthopedist for probable surgery. But before you do this, you review this hypothetical patient's medication history, and you find that one medication is yet to be prescribed. Would you prescribe it? The other half of family physicians were given the exact same scenario, but they were told for this hypothetical medical patient, 2 medications have yet to be prescribed. And for that 2 medication condition, it did include the medication from the 1 medication condition. And what was found is the family physicians were more likely to prescribe under the 1 medication option than under the 2 medication option. Because when you have the 2 medication option, now you had to weigh the relative pros and cons of both of those. And it may have been easier to say, you know what, I'm just going to send this person straight to the specialist. I think this has lots of relevance within healthcare. So one of the things that I kind of think about when I think about choice or information overload is some of the concerns about electronic health records and just the overwhelming amount of information that's contained in them. According to this concept, behavioral economics would really suggest that what you really want to do is you want to think about ways to actually reduce charting requirements when you can. In fact, behavioral economics has even gone so far as to suggest that eventually a manufacturer or a vendor of one of these electronic health record systems is eventually going to be sued, not because they didn't have something in there, but because they had too much information in there and clinicians couldn't actually follow the most important things they needed to actually chart and do. What about when it comes to interdisciplinary care? Certainly at a lot of pediatric institutions, there's a lot of emphasis on patients being seen by multiple providers. And don't get me wrong, in some situations this has a ton of value. But are there situations where patients are seeing multiple providers during a specialty visit, and then they walk away with 3 or 4 recommendations by 3 or 4 different providers, and they're overwhelmed with that information to the point they don't remember what they should do, or they just feel like, you know what, I'm not going to do anything at all because there's no way I can do all of these 15 things I'm asked to do. So when we think about the compromise effect and choice overload together, what is the optimal number of options? So there was a meta-analysis done across a wide range of conditions, and this was the overall conclusion. There's a curvilinear relation between the number of behavioral recommendations and improvements in behavioral and clinical measures, with a moderate number of recommendations producing the highest level of change. So this suggests sometimes you don't want to offer too many options, but you also don't want to offer too few options. Strategy number 4, something called loss aversion. So we as humans like gains. We dislike losses. But the size of our emotional response to those things may be very different. We really like gains, we really, 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 really dislike losses. Losses loom larger than gains. So before I talk about an example within healthcare, let me talk about putting during professional golf tournaments. So what they've done is they've actually observed the behavior of professional golfers across many, many rounds. And what they found is that professional golfers will actually putt better when they're putting for par than when they're putting for birdie. When you're putting for par, you're trying to avoid a loss. When you're putting for birdie, you're trying to actually get a gain. And they controlled for all the confounding factors, such as distance from the ball to the hole and where the ball was on the green. Losses loom larger than gains. So how does this apply to actually trying to promote differences within healthcare? So let's talk about an incentive schedule for adherence to a healthcare regimen. We're going to talk about 3 different financial options. So under the traditional option, if somebody is adherent for a time point, for example, they've exercised, they get a certain amount of money at the end of that time point, say $5. Under a loss aversion program, what happens? At time point 0, at the very beginning, they start off with a certain amount of money in their account, say $25. And they're told that for every time point they're not adherent, money will be deducted from that account. Third option, lottery. Basically, they're told for each time point they, quote, do the right thing, in this case, exercise, they get a small amount, say $250. Every now and then they get the larger amount, the $15. And what you're going to see is that basically if somebody is fully adherent, they get the same amount of money. So why does it matter how you schedule the incentives? Well, actually what Patel and colleagues found is at least when it came to adult exercise, the loss aversion worked best. That's actually what promoted the most exercise. The whole idea that if I feel like something is mine, it's in my account, I can't access it yet, but I feel like it's mine, then basically I don't want to lose something that's mine. It will actually motivate me to engage in the target behavior. There was a study in the New England Journal of Medicine the year before that actually found that loss aversion could be used for promoting smoking cessation. So under this situation, people would actually put some of their own money at risk, and they would actually lose that money at the end of the program if they couldn't actually biologically prove they're no longer a smoker. So you may say, why would anybody actually do this? Couple of reasons. One, they want to make that commitment that they really want to stop smoking. They feel like this is a way to actually promote that. The second reason is the experimenters actually would match some of this money so that if you actually stop smoking, you could actually come away with more money than you started. So let's wrap up and think about some challenges and opportunities for behavior economics moving forward. So I don't want to suggest to you that any of the strategies I've talked about are really, really well supported by the evidence, at least not yet. We need more evidence both in terms of adult health and pediatric health. And my guess is at the end of the day, these strategies are likely going to be context dependent. They're not going to be a panacea. Narula and colleagues did a study when it came to trying to encourage adults to show up for colonoscopies. And they compared the opt-in approach to the opt-out approach. So under the opt-in approach, a patient would get a letter stating, you are due for a colonoscopy. Please call this number or schedule a day and time for this appointment to occur. Under the opt-out approach, different patients would get a letter saying, you're due for a colonoscopy. Here is the day, time, and location for your individual appointment. What actually happened in this study is opt-in worked better than opt-out. People found like it was a little too presumptive, a little too forward to actually schedule that appointment ahead of time, and people didn't actually like that, even though I know I've been talking about the virtues of opt-out before. Sometimes people will look at these interventions and say, you know what, these are simple interventions. Families are really, really complicated. This isn't going to make any major difference. And again, I want you to step back and really question that assumption. Sometimes forgetfulness and difficulty swallowing pills are some of the leading barriers we have to adherence. Again, not a panacea, but do they have incremental value, these strategies, for what you're trying to accomplish for your objectives? I think if I were going to choose somebody to be an icon for behavioral economics, Yoda would be a good choice. I think Yoda might say something along the lines of, don't judge an intervention by its size. Third challenge, unknown acceptability to clinicians and patients. Some people don't want to be nudged. I don't think these strategies are going to work if you have somebody who's adamant they don't want to make a change. You may have to consider other strategies for those types of individuals. And we need to learn a little bit more about whether or not people are actually amenable to these strategies when it comes to changing behavior. And of course, there's a larger ethical issue here. Under what situations is it actually ethical to nudge anybody to do anything? I mean, after all, if we all have these cognitive biases and these limitations, if I design something, who's to suggest that the intended target really should actually do anything that I'm actually recommending for him or her? So when we think about retirement savings programs, behavioral economists love to pat themselves on the back. We've increased the number of employees who should be saving for retirement, but there's a little bit of a catch. Some employees should save nothing for retirement. If you have an employee who has really high-interest credit card debt or high-interest payday loans, they shouldn't be saving a dime for retirement. And even though those programs might make some sense for a lot of employees, it may not work for everybody. What about in healthcare? Are there situations where we should be trying to nudge people in healthcare? I'm going to suggest that there are. And to try to back up this point, I'm going to talk about an economist by the name of John Maynard Keynes. He is known as saying the following: in the long run, we're all dead. He wasn't concerned about our physical health. He was concerned about economic depressions. So there was an idea at the time that if an economy was in a depression, what you wanted to do is to just let it correct itself. And Keynes came along and said, wait a minute, there's going to be a lot of misery in the meantime. Let's actually have governments intervene with stimulus spending programs or tax cuts. I'm going to suggest to you that there's certain situations in which we want to reduce morbidity and mortality, and it's absolutely appropriate for us to be nudging when it comes to pediatric care. Vaccinations, I think, would be a classic example of that. So what are the take-home messages? Please try to remember this acronym, EAST: easy, attractive, social, and timely. You know, when I think about some of the changes that are happening within healthcare, so often people are talking about changes in things like genomics or informatics, and don't get me wrong, those are really important endeavors. But I think more and more people are talking about changes when it comes to behavioral change in terms of trying to improve health. And here's the piece of evidence that I'm going to give to support that assertion. There was a change 2 years ago to the medical college admission test. They added a new section, something called psychological, social, and biological foundations of behavior. It's 60% psychology, 30% sociology. I think it really emphasizes that behavior change matters within healthcare. So what are some possible next steps? So I find that reading works well for some people. Sometimes I find that discussing works well for other people, where they want to actually discuss their priorities and think about how it might actually apply some of these concepts to what they want to do. But if you are some people who might actually be interested in reading, what I want to do before I take questions is a little exercise, a little demonstration. So get out your handouts. And with this handout, let me show you what I've actually tried to do. I am using behavioral economics to encourage you to learn more about behavioral economics. And let me tell you how I did this. The first thing you're going to notice is that this handout looks a little different, right? It's a different size, shape, and color than most handouts. I want this to be able to stand out. I want you to be able to find this and remember this. The second thing you'll notice is that I did it very much under an opt-out approach as opposed to an opt-in approach. So under an opt-in approach, I would say, hey, just pick one up on your way out. A lot of people wouldn't get around to doing that. Under the opt-out approach, you're more likely to get a handout. Sure, you can leave it here, you can throw it away as soon as you get back to your office, but you're probably much more likely to get it under the opt-out approach than under opt-in. Now, if you look at the front side and see the Schaffer reference for a second, that's the 511-page book, and then you're going to see a second reference that's just 10 pages. I'm using something here called the compromise effect. So don't get me wrong, that Schaffer book is a great book. It really talks about behavioral economics very broadly, not only for healthcare purposes, but for things like changing educational outcomes or improving energy conservation. But my guess is by providing both of those references, that makes that second reference look much more feasible by comparison. Now flip it over for a second. So if I were going to critique myself and my own adherence to behavioral economics, what I would say is I might be guilty of choice overload. I've given a lot of concepts, a lot of examples, a lot of studies. So to try to mitigate that, what I've done is encouraged a few of my favorite BE references for specific topics that might be of interest to you. So with that, I thank you very much for your time and attention. I really appreciate the warm hospitality I've had here in D.C. I'd be happy to take comments and questions.
I have the mic, which means I can say something. So it's interesting, David and Denise, we get these top performing doctor letters, right? It's interesting. Kathy, when we round, you sign those boards. making a public commitment. So it's interesting. It's good to see we do some things, you know, that are in line with behavioral economics. Questions?
Thank you so much. That was fascinating and very well presented.
Thank you.
I was wondering if you could comment on any data or work that has been done in rolling out bundles of interventions in terms of one at a time versus all at once?
Great question. So I'm not aware of anything specific in that regard. And again, this is actually a really tough one because my understanding is when it really comes to the bundle and the bundle compliance, there's a justification for trying to do all these things together that basically you have an overall synergistic effect. My concern from a BE standpoint is, again, whenever you ask people to do 6 new things, it's going to be more challenging than to ask to do one thing and incrementally add it. So I think how I would try to remedy that potential conflict is to suggest that if you're going to use a bundle or some type of checklist, you've got to make sure that there's high priority for doing it. You know, I think this is one thing that behavioral economics really talks about. It doesn't just talk about nudging. It talks about something entitled, why nudge? Which really means that you really have to distill and think what are the most important interventions you want to work on. So again, it's not that I would say get rid of bundles or get rid of those things, but I would suggest, you know what, don't roll out too many at a time and really think about, can you justify why this was an area of emphasis as opposed to something else? Good question.
My take home for bundles is we're going to make everyone opt out. Just kidding. No, but it was well said.
Hey there, again, great. I really appreciate it. It fits in what I'm trying to do in this hospital very clearly, is those of you who have met me so far.
Everybody knows.
Can you introduce yourself?
I'm Mark Dominici. I'm your new manager of clinical documentation improvement. We call it clinical documentation excellence. So I am looking to change your behavior very clearly. But my question is not to that regard. My question is more towards vaccination. Please don't get me wrong. I vaccinate all 9 of my children. But my question is, doesn't the vaccination example violate the ethical principle of autonomy, or can you violate that ethical principle? I know beneficence is very, very important, but when we take away and we just say, hey, I'm going to vaccinate you, we don't give that patient the choice anymore.
Great question that comes up. And again, I'm not going to say that I have any magic answer to that. But again, I think what BE would suggest is you're not completely taking away the autonomy, you're nudging. So in my opinion, completely taking away the autonomy would be, you know, let's distract the parent, get them in another room, and give the kid a shot, right? That's completely taking it away. Saying, you know, we have some shots we need to do today, and at least having the parent have a chance to step back and say, no, I don't want that to happen, or ask questions, that I think is more consistent with nudging, and there could be an actual justification for it. I think the other thing that I would say in that regard is, again, we don't want to use nudging for everything. And this is where we have to think a little bit about is who do we ultimately want to benefit? If we have certain pieces of information and knowledge that sometimes parents don't have, should we be motivated? Should we actually try to do some of this because it may actually be in the longer run interest of the patient? Even though there'd be some situations where absolutely parents wouldn't necessarily like that a lot, and they might even have some concerns about it. So again, nothing's a panacea. My guess is in certain situations that approach might kind of backfire, but on a broader approach, what I would suggest to you is I think opt-out, you could really say in the situation, could be deemed professionally acceptable and probably clinically the right thing to really seriously consider. But your concern is well-founded.
All right, last question, and then I think Kathy's going to wrap this up.
Hi, I'm Danny Lewis. Hello, Sleep
Hi, nice
fellow
to see you.
person. So has this been implemented, I mean, in broad training rather than in just narrow ways, so training a whole hospital how to implement this in specific domains where it can be made more relevant to individual specialties?
So the closest thing that I'm aware of in that regard is the University of Pennsylvania has a group called the Center for Health Incentives and Behavioral Economics. But what they do at the University of Pennsylvania with their group is about 90% of their work, to my understanding, is very adult-focused. So I'm not aware of large institutions outside of that have really rolled this out in a large way. And again, you know, part of me would be kind of excited by that possibility, but again, I think we really need to do this at least a little bit in some incremental steps to see really whether or not that's going to be warranted before we think about kind of wide-scale approaches of doing that. But probably the group at Penn is the closest to actually doing what you're talking about. Does that answer your question?
just going to have Kathy conclude for us, if we don't mind, just so we can get everyone back to their clinical duties. Kathy.
Okay, great. Well, thank you, Dr. Shah. Thank you so much, Jack. That was really, really enlightening. Excellent. I think what I would challenge us all to do, and I know I saw Brian leave, but as we're getting ready to roll out a new clinical documentation enhancement piece for the physicians, is to think about how we can use BE to change our practices. And when I was sitting there thinking, although you know, you didn't talk specifically about breakthroughs in safety, I know that they're probably there. Some of the conversations we've had over the years as we've done all of these root causes is, gosh, how many checklists do we really need, right? And to your point around bundles, we do need bundles. We're not getting rid of those. We do need those. But how can we simplify things for our frontline providers, our frontline nurses, our doctors, in giving the care that they give? So I think you've given us some really good things to think about, and we appreciate that. I also really like the point around recognizing when we're doing something right. So when we think about our principles around safety, that's the 5-to-1 feedback. That is really acknowledging that somebody did something great. So more smiley faces in the electronic health record for documenting would be great, instead of versus saying you didn't do X. But so I think we just need to be thinking about this in a very different way. So we thank you for that. And just want to come back to our patient, Sydney Snyder, and why we're all here. I think that, you know, as we leave this auditorium, we think about this talk and how we can do things better and differently, and never forget who we're caring for, and that's our patients, and how important Sydney was to us and us thinking about safety and our safety journey. So thank you, Jack, and thank you, Sydney. Thank you.